Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nick Nickham. Today we are going to be talking about hypertension, management basics. The normal blood pressure is systolic less than 120 and diastolic less than 80. This is based on JNC 7 and 2017 American College of Cardiology and American Heart Association. Prehypertension is defined as a blood pressure between 120 to 129 over less than 80 millimeters of mercury, whereas the ACC-AHA defines it as elevated blood pressure. Stage 1 hypertension, and as you can see, there are some differences here. As you can see, we got some differences here, but we are going to stick to 2017 ACC-AHA guidelines. Between 130 and 139 systolic and diastolic 80 to 89 is considered stage 1 hypertension. When the blood pressure is between 140 to 159 and the diastolic between 90 and 99, it is considered stage 2 hypertension. Whereas blood pressure over 160 and the diastolic over 100 is considered as a stage 2 in the JNC, and it's also considered as a stage 2 in the ACC-AHA guidelines. The main thing to understand is that anytime a blood pressure is over 130 and a diastolic over 80, that is something considered as hypertension, and the degree of hypertension depends upon the systolic and the diastolic blood pressures. It also determines how we approach these patients in terms of treatment. So that's what we're going to learn in this presentation. All right. In addition to the blood pressure we are talking about, the risk of cardiovascular diseases goes up when there are other associated risk factors. If the patient has no risk factors, a normal blood pressure can have minimal effects. However, if there are no risk factors and still if the blood pressure is grade 2, it increases the risk of morbidity and mortality. Similarly, if you have one or more risk factors like hyperlipidemia, diabetes, peripheral arterial disease, then the risk progressively goes up with the level of the blood pressure. On the other hand, if the patient has multiple risk factors like kidney disease, diabetes, cardiovascular diseases, then the risk of hypertension becomes exceedingly high. One of the greatest risks related to hypertension is stroke, and by appropriately treating the blood pressure, we can reduce the incidence of a stroke by almost 60%. That's one of the main reasons to manage your blood pressure. The other reasons include preservation of renal function and also end organ damage. Let's look at some of the drugs that are commonly used in treatment of hypertension. We have various classes of drugs, starting with diuretics, ACE or ARBs, vasodilators, beta blockers, alpha blockers. Then we have intravenous drugs for hypertensive emergencies. So we're going to first get familiarized with these drugs. Then we're going to determine as how and where we use a particular drug or a particular combination of drug given the patient circumstances. Hydrochlorothiazide or HCTZ has been around for a long time, and it is given a dose of 12.5 to 25 milligrams, and it is supposed to reduce the blood pressure by eliminating the sodium. However, it may be associated with some electrolyte imbalances such as low potassium or low magnesium, which needs to be monitored. Lasix is a loop diuretic which is more powerful than hydrochlorothiazide, and it is usually used in patients with associated other conditions like renal insufficiency or heart failure or patients who have fluid retention. Chlorthalidone is another diuretic, which is a mild diuretic. However, this diuretic has been shown to reduce the overall mortality in patients treated with this drug alone or along with other drugs for hypertension. Bumax is a similar diuretic, like a loop diuretic. It sometimes works better in patients who do not respond to Lasix. Aldactone is a potassium-sparing diuretic. It is generally used in patients with a chronic heart failure, especially those who are in stage 3 or more. Now let's shift to ACE or ARBs. One of the important things I would like to mention is whenever you are selecting drugs for hypertension, always learn one particular drug in each class or 2 drugs very well, so that you know what dosages to use, what side effects to look for, so that you are very familiar with the drug's action with various types of patients. So lisinopril is the most commonly used drug. There are multiple other ACE inhibitors, but as I said, you just need to stick to one. For the longest period, I use enalapril or Vasotec as it used to be. It is still available, and in fact, it is used intravenously in acute situations to bring the blood pressure down. Lisinopril dose is like 10 to 40 milligrams daily. It can be given once or twice daily. I prefer to give these drugs twice daily, so you have a pretty steady serum level throughout the day, so it maintains the blood pressure much more smoothly compared to once a day dose. The side effects you need to worry about are cough, which is related to the bradykinin release in the lung tissue. And if patients have persistent dry cough, then you can switch to an ARB or angiotensin receptor blocker. I would just stick to one drug. As I said, I most often use losartan. Losartan is given in a dose ranging from 25 to 100 milligrams per day. It is generally given once a day, but I think when you give it twice a day, it works much better because of a steady serum level. So it keeps the morning blood pressures lower instead of when you give this drug once a day where the morning blood pressures may be creeping up. Valsartan is another drug, but as I said, I just stick to one drug in each class so that I'm very familiar with how the drug works and I'm familiar with the population. I use these drugs so I know how they are going to respond. Now let's look at some vasodilators, and in this category we have the calcium channel blockers, namely cordizem or diltiazem, and we also have verapamil, which is also a calcium channel blocker, and along with that we also have Procordia or Procordia XL. Cordizem is given as every 8 hours dose, or nowadays we have a long acting or Cordizem CD, which is given once a day. The dose ranges from 120 to 360 milligrams per day. Verapamil is a drug which works not only in reducing blood pressure, it also increases the AB node blockade, and it acts like a beta blocker in terms of reducing the heart rate in patients, especially with atrial fibrillation. Verapamil dose can range from again 120 milligrams to 480 milligrams. There is also a long-acting verapamil that you can use, but in an acute situation, it is advisable to start off with a slow, short-acting verapamil and then gradually increase the dose depending upon how the blood pressure is responding. Nicardipine is another class of vasodilators that you can use. I don't generally use this one. If we use it, it is used mostly in the hospital setting. Amlodipine is a very popular calcium channel blocker. It comes in dose of 5 to 10 milligrams daily. It can be given once a day. The side effects include fluid retention and some dizziness. Hydralazine is a potent vasodilator. It can be given orally or intravenously. It is given intravenously in an acute situation. However, hydralazine should be avoided in patients with ischemic heart disease or acute coronary syndrome or those who have abnormalities suggestive of ischemia. Let's move on to beta blockers. The most commonly used beta blockers are Coreg, metoprolol, propranolol, and atenolol. There are other beta blockers that are available in the market, but as I said, I would recommend that you become used to one or two drugs that you can commonly use. For the longest time, for decades, I used atenolol because that drug was available. It was generic. It was costing less than peanuts. And so atenolol, the dose is anywhere from 25 milligrams once a day to 200 milligrams per day. And it works even better if it's given twice daily. Let's talk about Coreg. The Coreg is not only a beta blocker, it is also an alpha stimulant. So it has several advantages in patients with heart failure, especially systolic heart failure. And the dose of Coreg is from 3.125 milligrams twice daily all the way to 25 milligrams twice daily. Now we have various forms of long-acting Coreg, which can be given once a day up to 80 milligrams. So you just have to look and see which one suits best for your patient. Metoprolol similarly is a beta blocker, which also increases AV blockade. So it is not only used in hypertension, it is also used in patients with heart failure. It is also used in patients with heart failure and also in patients with atrial fibrillation for control of a ventricular response. In patients with severe COPD who cannot tolerate metoprolol for rate control in atrial fibrillation, we can use verapamil intravenously or orally to control the rate, which does not cause bronchospasm. That is verapamil. Okay, propranolol has been around for the longest period. It is a non-selective beta blocker, whereas metoprolol and atenolol are beta-1 beta blockers, which primarily act on the myocardial tissue. Propranolol dose can range from 40 milligrams to 160 milligrams a day. This is not very often used in the present day, but there are some patients who have been on it for a long time who would prefer to have that drug. Atenolol, I already talked about atenolol, which was a favorite drug in the 70s, 80s, and 90s. Today, the two most important drugs are Coreg and metoprolol. Between Coreg and metoprolol, Coreg has a much better blood pressure control compared to metoprolol. Now let's move on to alpha blockers, some of which are peripheral alpha blockers, and clonidine, which is a centrally acting alpha blocker. There are various drugs in this category. Doxorubicin is one, which is a very potent alpha blocker, and it, in a dose of 1 to 8 milligrams, can drastically reduce the blood pressure. Prazosin, or mini-pres as it is called, it can be used in dosages ranging from 1 to 4 milligrams, and again it also helps to lower the blood pressure. Tamsulosin, even though it is an alpha blocker, it is generally used for benign prostatic hypertrophy, but nonetheless we need to be aware that tamsulosin can drop blood pressure, and hence the blood pressure has to be monitored when starting patients on tamsulosin. Clonidine is given in a dose ranging from 0.1 to 0.3 milligrams every 8 hours. Clonidine is a very potent antihypertensive medication. It can be used in patients with hypertensive emergencies, and it is given usually as a 0.1 or 0.2 milligrams orally, and it generally brings the blood pressure down within like 2 to 4 hours. Clonidine has a tendency to slow the heart rate and also cause drowsiness. So if patients have very significant bradycardia or heart blocks, you need to use this with caution. Intravenously, we have nitrates, diltiazem, nicardipine, nitroprusside or nipride, lobetalol, hydralazine, and enalapril. I'll talk about this in a little more detail in the upcoming slides. We also have a direct renin inhibitor. This is a new drug which can be tried if some of these other drugs or a combination of drugs don't bring the blood pressure down. Okay, now let's start off as how do we select a drug based on a given patient? One thing I want to emphasize is treatment of hypertension is highly tailor-made, in the sense the treatment and the selection of drugs for hypertension depends upon all the underlying medical conditions, age, sex, and race, plus other medical associated conditions. So if you have a younger person, less than 55 years, if that person has this mild hypertension, that person can be started on either an ACE inhibitor such as lisinopril or losartan, which I talked about, and a single drug may be able to control their blood pressure. However, if that person is 55 or older, or if you're dealing with a black patient of any age, preferred choice would be a calcium channel blocker such as cardizem or amlodipine, along with a thiazide diuretic. In the old days, the diuretics were the first line of drugs, but this is the first thing we want to remember. The first line of drug in the treatment of hypertension is either an ACE or an ARB. If they can't tolerate the ACE, then you can use ARBs. If the blood pressure is much higher and if they are not controlled on a combination of 2 drugs, then we move on to a combination of 3 drugs, namely a diuretic along with a calcium channel blocker and an ACE inhibitor or an ARB. So that is in moderate to severe hypertension. If some of these patients are not controlled, then we need to look at using more potent drugs like clonidine to control the blood pressure. When these things fail to control the blood pressure, we can look at other treatment modalities such as using a more potent loop diuretic, or we can use an alpha blocker like doxorubicin, Minipress or prazosin, or even using a beta blocker as a combination to bring the blood pressure down. Our aim is to bring the blood pressure down to 130 over 90 millimeters of mercury or less, and again that depends upon the age of the patient. As the patient gets older, the numbers go higher, especially the systolic numbers. So if you're dealing with a person who is 70 years old, 130 may be too low to maintain cerebral and renal perfusion. So these patients may need a slightly higher blood pressure, like 150, even 160. Few words about treatment of hypertension in pregnancy. We have very limited number of drugs that we can use in patients who are pregnant because of the risk of causing developmental problems in the fetus. So the drugs that have been found to be useful in these patients include hydralazine, which is a vasodilator, which I talked about. Then we have nifedipine, which is another agent that reduces the blood pressure. Lobetalol is a beta blocker. It can be given intravenously in an emergency situation like delivery, something like that, or it can be given orally. And of course, the oldest drug which has been around for a long time, namely methyl dopa or Aldomet has been found to be the safest drug in patients who are pregnant. Of course, magnesium sulfate has also been used in hypertensive emergencies in pregnant patients. We talked about what drugs to start based on the age and the severity of blood pressure. Let's look at it from a different perspective. How about what drug do we choose based upon pre-existing conditions like multiple risk factors like diabetes, kidney disease, coronary artery disease, ischemic stroke, or left ventricular dysfunction, either systolic or diastolic. If it's mainly a primary prevention for a very mild hypertension, we can use either a thiazide diuretic, ACE inhibitor, or an ARB. And if the blood pressure is still not controlled, we can use a combination of a diuretic and an ACE or an ARB. If we are dealing with a diabetic patient, of course, you want to use ACE inhibitors, which is supposed to preserve renal function, reduce proteinuria. It can also be combined with the thiazide diuretics or calcium channel blockers or beta blockers. If we are dealing with the chronic kidney patients, ACE inhibitors would be quite useful. However, if the patients are having an acute kidney injury, we need to avoid ACE inhibitors because ACE inhibitors can increase the serum creatinine level. Even in those patients who are on stable chronic kidney disease, when ACE inhibitors are given, it can increase the creatinine level by almost 1 point and it will stabilize and stay there. So that should not be a concern. When we are dealing with the patients with the coronary artery disease, of course, we can use beta blockers, which would help not only in controlling the blood pressure, but also in patients with ischemic heart disease. Similarly, ACE inhibitors are going to be quite useful, and the ACE inhibitors also have the advantage of improving mortality in patients with coronary artery disease, with left ventricular dysfunction, especially if they have a left ventricular ejection fraction less than 40%. So they can be also combined with the thiazide diuretics for blood pressure control. And of course, we can add calcium channel blockers for ischemic control if these two drugs do not control the blood pressure in patients with pre-existing coronary artery disease. If a patient has a previous history of a stroke, the choices of drug would be ACE inhibitors and a thiazide diuretic, especially something like chlorthalidone, which are shown to reduce morbidity and mortality. When we are dealing with patients with hypertension and systolic heart failure, now we are talking about primarily ACE or ARBs combined with thiazide or loop diuretics. And of course, along with that, we're going to be using a beta blocker such as Coreg or carvedilol or metoprolol. When they reach stage 3 or greater, aldactone antagonists can be used, namely aldosterone can be used. Hydralazine and isosorbide dinitrate combination has been found to be useful in reducing mortality in patients with left ventricular dysfunction, especially in the black population. So this is particularly useful if you are dealing with a particular population to know which drug works better. When we are talking about calcium channel blockers, I do want to make a point that if the left ventricular ejection fraction is less than 40%, we should try to avoid calcium channel blockers and treat them with loop diuretics along with ACE or ARBs, then use cardioselective beta blockers so that we get the best outcome in patients with systolic heart failure with the ejection fraction of less than 40%. So these are some of the things which are very important for us to pay attention to. And here is a very extensive chart which talks about dealing with hypertensive emergencies. These are all the intravenous medications that are available. You can pause the video, take a look at it, and make a note of this or find this chart by looking for it in the Google Images so that you can have it readily available when you're dealing with an hypertensive emergency. Let me just touch upon some of the most commonly used drugs in an hypertensive emergency. We can use clonidine. If the patient is not having major symptoms, clonidine 0.1 to 0.2 milligram orally, and it works within 30 to 60 minutes and it lasts for 6 to 8 hours. It can cause sedation. It can also reduce heart rate, slow the heart rate. That's an important thing. But if we have a patient in an intensive care unit, we can use enalapril intravenously in a dose ranging from 1.25 milligrams every 6 hours. If you are dealing with a patient with a coronary artery disease with an acute coronary syndrome, then the best choice would be nitroglycerin at 0.25 to 5 micrograms per kg per minute intravenously, and we need to watch for hypotension, headache, and bradycardia. The most widely used drug is nitroprusside or nipride, which is a vasodilator, and it works within seconds. It is given as an intravenous infusion, so you can titrate the dosage so that you have a much better control over the blood pressure. Some of the other drugs listed here are used infrequently. Labetalol can be given intravenously in a dose ranging from 20 to 40 milligrams every 10 minutes. It acts within 5 to 10 minutes and lasts for 3 to 6 hours. Once you start these patients on intravenous boluses, it needs to be followed by long-acting medications for continuous blood pressure control involving either nitroglycerin, nitroprusside, or nicardipine intravenously. So these are some of the things that we need to be keeping in mind. Here may be a simpler chart showing what are the things that we can use. Sodium nitroprusside, nitroglycerin, nicardipine. Hydralazine can be given in 10 to 20 milligram IV injection. It works within 10 to 20 minutes, but as I said, hydralazine needs to be avoided in patients with ischemic heart disease. We talked about labetalol. We don't use phentolamine very often, but it is used in the operating rooms for control of blood pressure. So just familiarize yourself with this particular chart when you are dealing with an hypertensive emergency, so you will be very well equipped to manage any patients who comes to the hospital with a blood pressure of like 220 over 130. So ladies and gentlemen, this is a brief, quick overview of hypertension treatment in the clinical setting, in the office, in the hospital, and in the intensive care unit. Thank you so much for watching this presentation. Please do subscribe to our YouTube channel, and we will see you next time.